All right. My presentation is on gender disparities in mental health care and research, a consideration for premenstrual disorders. So this presentation will be sort of a crash course on premenstrual disorders, what they are and why they're so important for mental health clinicians to have a basic understanding of them and to have an awareness of them. So today we'll be covering the definitions, prevalence, and etiology of these disorders, their diagnostic barriers, transgender and non-binary experiences, as well as their treatment. And then at the end, I will provide some key takeaways for everybody. So, menstruation and hormone fluctuations are an integral part of the female reproductive years. Variations within and between women for their cycles are very normal. And these variations are not always a sign of poor health or infertility. However, some variations are harmful, and these can be categorized as premenstrual disorders or PMDs. And these can affect your social life, academic life, work life, and personal well-being. Um, The US stats are not known, but according to a Canadian study, about 50% of admitted psychiatric patients are women. Um, Therefore, it's important to consider premenstrual disturbances when researching and providing services to female patients, no matter their kind of psychological issues that they're dealing with, because a large portion of psychiatric, both inpatients and outpatients, experience menstruation. All right, so this part would be a little bit dense, but it's important to have a basic understanding of these disorders. Um, so starting with there are definitions and prevalence. Um, so what are premenstrual disorders, PMDs? So PMDs encompass premenstrual syndrome, which is PMS, premenstrual dysphoric disorder, PMDD, and premenstrual exacerbation, which is PME. They are all conditions experienced by females of reproductive age, characterized by physiological, psychological, and behavioral symptoms. They affect your social life, academic life, work life, and personal well-being, as stated earlier. Um, as for when they occur during the days leading up to menstruation in a period called the luteal or premenstrual phase, which is the phase of the menstrual cycle that occurs after ovulation and before menstruation. And these symptoms cease around the start of menstruation. Okay, so premenstrual syndrome. This occurs typically 1 to 2 weeks before menstruation begins. The symptoms can last from a few days to 2 weeks, typically subsiding at the start of menstruation. In terms of prevalence, for the US female population, it's roughly 20 to 30%. And the global female population, it is 47.8%. Just to put that into perspective, that is nearly half of the entire global female population. And also 80 to 90% of the entire female population experiences at least one PMS symptom each month. That is a huge percentage. So what are the symptoms of this disorder? So they include affective, behavioral, and somatic or physical symptoms. As for affective symptoms, these are depression, mood swings, irritability, anxiety/tension, confusion, and feeling out of control. As for behavioral symptoms, these are sleep disturbances, appetite changes, poor concentration, decreased interest, and social withdrawal. And as for physical symptoms, these are swelling, breast tenderness, aches, headache, and abdominal bloating. All right, now we have premenstrual dysphoric disorder, PMDD. This is often known as a more severe form of PMS, and it is a disorder that is officially recognized by the DSM. I believe it was officially recognized in 2013. So this disorder occurs most of the time during the week before menstruation and subsides during the week menstruation begins. Usually, I want to say they subside after like the third day at the latest. Um, To receive a diagnosis of PMDD, you need symptom monitoring for over 2 cycles, and other physical and emotional disorders must be ruled out. As for the prevalence of PMDD for the US female population, it is about 3 to 8%. And the global female population, it's about 3.2%, which does not include provisional diagnosis, which is basically a diagnosis that's not really, it's not official yet. It's kind of a doctor's best guess that you do have PMDD, but they're not 100% sure yet, which is, I think, if you kind of provisional diagnosis, it'd be, I think the study said 7%. So as for the symptoms of PMDD, I grabbed this straight from the DSM. These include depressed mood, anxiety/tension, mood swings, irritability, decreased interest, concentration, um, difficulties, fatigue, appetite changes and food cravings, insomnia/hypersomnia, feeling out of control, and then there's physical symptoms, which they were not very specific about in the DSM. Um, so you need at least 5 of these 11 symptoms. Um, to be present in most menstrual cycles for at least 1 year to get a diagnosis. Um, Additionally, suicidality is also a common symptom of PMDD. And then there's premenstrual exacerbation, PME. So this issue is technically not a disorder, but can be considered a variant of premenstrual disorders. It's defined as the worsening or exacerbation of an existing psychiatric illness during the premenstrual phase. There are a couple big studies who provide a more comprehensive view of how a variety of psychiatric disorders may manifest in the premenstrual phase, which are going to be linked at the end. And I highly recommend people check it out no matter what you plan on going into in this field. Um, in terms of frequency of PME, there was a Chinese study that was using a sample of about 50 outpatients who were female, and they found pretty high rates of premenstrual exacerbation among them, especially those with depression and anxiety. However, the overall prevalence of PME is unknown, which is not surprising. And then as for the etiology of these disorders, large gaps still exist in this knowledge, but some studies have suggested that hormones, the immune system, the neuroendocrine system, and genetics all play their own role in these disorders. All right, so as for diagnostic barriers, these can lead to an absence of diagnosis, late diagnosis, or misdiagnosis for these disorders. There was a comprehensive review that found these following barriers, and these were specifically for PMDD, but in my opinion, they can be sort of, oh my gosh, what's the word? You can translate these to other disorders, so PMS and then PME. So on the individual level, these barriers included internalized norms and stigma that deter help seeking, medical trauma and mistrust, feelings of fear, shame, self-blame, and confusion, and diminish autonomy and increase side effects from prescribed PMDD treatments. On the medical side, there were limited provider knowledge, non-adherence to diagnostic and treatment guidelines, and negative patient-provider interactions. On the cultural level, there was reproductive and mental health stigma, gender and cultural norms, and cultural preferences for alternative medicine that reduce access to pharmacological treatment. And then finally, on the structural level, there was fragmented healthcare and limited access to health services. There was also another study that had pretty similar findings. They described 3 different types of barriers: patient, provider, and societal, similar to the last one. So as for patient barriers, these were not discussing symptoms with others, not challenging doctors who provide a misdiagnosis, and not having easy access to healthcare. As for provider barriers, which are very relevant to all of us, There was a denial of PMDD as a real diagnosis, and um, it was because these providers said that the diagnosis was just so recent and they just didn't recognize it as a real thing yet. I can't remember if they actually said this or if it was just an assumption by the researchers. But anyway, then there was medical gaslighting, which, as we all know, is basically when a provider dismisses a patient's symptoms. And then, as for female versus male providers, these findings were pretty interesting. So there was a study that said that participants stated that male providers were a bit more domineering and they felt like they knew everything. They were also very disrespectful when it came to dealing with female patients who had these sorts of symptoms. Um, as for female providers, they showed a bit more empathy than the male providers, but at the same time, there's kind of a lack of sympathy at the same time for female patients because this was thought because female providers also deal with menstruation. So because they also experience menstruation each month, they kind of see these severe symptoms and they think, oh well, I deal with symptoms like that, you know. So it kind of doesn't matter to them. So that's something that we as providers should look out for. We shouldn't just dismiss symptoms because we also deal with similar symptoms. Um, Part of this presentation is to explain to both, well, to all genders that not every person who menstruates experiences their cycle in the exact same way. All right. So finally, as for societal barriers, these were menstrual stigma, um, the expectation, and the expectation that women should be selfless, should care for others, and should simply deal with the pain that comes with menstrual cycle because it is part of being a woman. And these expectations ultimately lead to women suffering in silence. So these diagnostic barriers obviously all have consequences, which include late diagnosis and misdiagnosis. So this is really the heart of the presentation. So in terms of late diagnosis, PMDD symptoms typically appear around age 15 on average, yet the average age of diagnosis is age 35. So just putting that into perspective, that's about 20 years of enduring symptoms without having proper treatment. People should not be going that long without a diagnosis and without proper treatment for these types of issues or for really any serious issue they're dealing with. And in terms of misdiagnosis, this rate is unknown, unfortunately, but some studies have found common diagnoses of bipolar disorder and borderline personality disorder. Other potential misdiagnoses are schizophrenia, chronic fatigue, post-traumatic stress disorder, and cluster B personality disorder. And this point is really important to take home, and it will be said again at the very end. Improper diagnosis of premenstrual disorders can lead to inadequate and potentially harmful treatments, while late diagnosis can increase the risk of suicidality and other harmful symptoms. All right, so as for transgender and non-binary experiences, maybe some of you can guess what the research of this looks like, which is a whole lot of nothing. Um, we don't know the prevalence of these disorders in this population. We don't know their manifestations in these populations, and we don't know the effects on their quality of life. What we do know in some research is that dysphoria is present in transgender and non-binary people, especially in youth, um, when it comes to menstruation. But we don't know, I guess we don't know how they feel if they when any of them have a PMD, but we can only assume that dysphoria probably is very much present for these people. And that's why it's so important for us as clinicians to be supportive and to be um, reliable allies for these individuals. But yeah, so of course, this goes without saying, future research definitely needs to include more of these populations, but also it's important to recognize that there may be dysphoria or just feelings of discomfort by being parts of these studies and by even talking about these issues. So that's something to consider as well, is that these populations may not even feel comfortable coming out about these things. All right, and finally, we have treatment. So the types of treatment that have been studied and recommended for premenstrual disorders are hormone treatment, antidepressant medication, herbal treatment, non-pharmacological treatment, and then surgical treatment. So as for hormone treatment, these include oral contraceptives and GnRH agonists, which I don't know much about that, if I'm being honest. But they found that oral contraceptives were the most effective. As for antidepressant medication, I'm not going to read this whole list of meds, but they found that fluoxetine, even over sertraline, was the most effective in treating PMDs, especially in terms of reducing symptoms of irritability. It also had the least side effects. As for herbal treatment, these included chasteberry extract, saffron, and I, I forgot how to pronounce that one. I'm so sorry. They found that saffron was the most effective in treating PMD. Um, all right. And then as for non-pharmacological treatments, I just want to preface this by saying the researchers did recommend that clinicians um, suggest these treatments before any other type of treatment. So they said non-pharmacological before anything else. And I'm guessing because these provide the least amount of side effects. So these treatments include cognitive behavioral therapy, supplementation, especially B6, vitamin D, zinc, and calcium, changing to a healthier lifestyle, such as reducing unhealthy food, alcohol, and smoking, and then aerobic exercise and yoga. And finally, we have surgical treatment, which includes hysterectomy and then thermal ablation of the endometrium. Of course, these do come with bad side effects and they're very invasive. So, and they're typically for severe forms of PMS, just to put that out there. It's definitely never surgical is always like the last resort. But for people with very severe PMS, it can work, but they are typically recommended hormone treatment before surgery. All right. As for the key takeaways, um, it's important to know that expertise is not necessary in this area for all clinicians. My point of this whole presentation isn't to tell you like you need to really study up on these things. You really don't. Just all I'm asking is really to develop a basic understanding of these issues, and I hope you receive that to some degree after this. Also, misdiagnosis can lead to inappropriate and harmful treatments. That's never good. Late diagnosis can lead to worsening symptoms and suicidality. That's also never good. Um, it's important to remember that PMDs can mimic other disorders and vice versa. That's a huge takeaway because I know that a lot of people will be specializing in other disorders and other populations, but just because you're not going to be specializing in premenstrual disorders, it does not mean that you won't see them, um, especially premenstrual exacerbation. Also, a good takeaway is to learn how to destigmatize menstruation. We have to learn how we basically perceive and value women and what they go through in terms of these things. And then finally, of course, for further research and training is needed, especially for trans and non-binary individuals. All right, and on this last slide, I just have about 4 studies that I would recommend everybody just check out, skim over, save them to a file somewhere, whatever you want to do. Because I think all of these, or most of these, or the first 2 at least, are relevant to everybody, and the last two are more so specific to, I guess, if you just want to learn more about these disorders and what people go through with them. So the first two studies are how the menstrual cycle affects other disorders. These two studies really provide a really good breakdown of that. So let's say you want to go into mood disorders. These studies go into how the menstrual cycle affect those disorders. And then there's the burden of PMDD, pretty self-explanatory. And then I have a study at the end here that was mentioned earlier, I think only like 2 slides ago, about the treatments and etiology of these disorders. All right, thank you so much for watching, and I hope you all took something away from this. Thank you.